This meeting is now being recorded.
And good afternoon, everyone, and thank you to Sue and for Mi-CCSI for inviting me to present the second in a series of webinars on asthma and COPD. Perhaps some of you tuned in last week for the initial webinar, and that was on asthma diagnosis and management. Today, we're going to be talking about asthma medications, the pharmacotherapy, the meds that are used to treat and manage asthma, as well as how to identify how to step up therapy when asthma is not controlled and step therapy back down when it is under control. So feel free to ask questions in the chat room or at the end, and I'm happy to answer any questions you may have. We're going to begin with just a brief overview of the two basic categories of asthma medications. There's the quick relief category as well as a long-term control. And quick relief meds we're all familiar with. This includes a short-acting beta agonist such as albuterol. There's also inhaled anticholinergics like APRN, and then there's even systemic corticosteroids. You may not think of oral steroids as quick relief, but indeed they are. They're fairly fast-acting, and they certainly are used in the emergency department in an urgent or acute asthma exacerbation. Then the long-term control medications also include corticosteroids, but these are the inhaled version of those. Cromolyn sodium, we'll talk about that. That's not used much anymore, but it is still in the guidelines. It's still in the market. Long-acting inhaled beta agonists, theophylline, again, also not used much anymore in asthma, but still in the market, still in the guidelines. And then finally, leukotriene receptor antagonists, LTRA. These are meds such as Singulair. So let's begin with reviewing the quick relief medications. These involve the short-acting beta agonists, or you'll hear them referred to as SABAs. And this includes albuterol, and there are multiple brand names for albuterol, as well as levalbuterol, or Xopenex, which is just a refined or enhanced version of albuterol. They've taken away some of the components that can cause the jitteriness. But basically, they all do the same thing. They relax the bronchial smooth muscles and open up the airways and help someone breathe. And we talked about that last week. When you have asthma and you have an acute exacerbation, those bronchial smooth muscle bands that surround the airways go into spasm, and they clamp down and squeeze the airways and make it difficult to breathe. There's also airway inflammation going on. There's increased mucus production. These medications don't treat inflammation or the mucus. They simply open the airways by relaxing the muscle bands. So they are to be used acutely. They are very short-acting. They work within 10 to 15 minutes, oftentimes sooner than that. They work pretty quickly, and they last maybe 4 to 6 hours. Their role is to bind to and activate the beta receptors that we have in our cardiac and smooth muscles. So when they activate the beta receptors in the lungs, it causes bronchodilation. However, they can also activate the beta receptors in the cardiac muscle, which causes tachycardia. And when they activate the beta receptors in the smooth muscles, that can actually cause the shakiness or the tremors. So those are just some side effects. They're typically not serious, and they usually will pass very quickly. The main effect that we're looking for is the bronchodilation in the lungs. Now, there are some older beta blockers that contraindicate in asthma because they can cause the opposite effect. So instead of beta agonists or activating those receptors, they block those receptors, and that can actually cause bronchoconstriction. So sometimes people who have asthma may find that their asthma has worsened when they're using those older non-specific beta blockers. So those could be contraindicated in someone with asthma. The problem with these medications is they are very effective, they're highly effective, they work very quickly. The problem is people tend to overuse them because they are so effective. They can feel the relief within minutes. So I have asthma. If anybody listening has asthma and has ever used one of these, you can feel the effect within minutes. Not only because you can breathe better, but you can also, you feel the heart racing a little bit, and you can feel a little bit shaky, so you know the medicine is working. The problem is people tend to overuse this because they don't realize that they're not treating the underlying inflammation, so they tend to use more and more, especially when you're in an acute situation and you can't breathe. That's when people tend to really overuse this. But we'll talk about in a minute what appropriate use of these types of medications should look like. It is the most effective medication for relief of acute symptoms. The red flag is using more than 2 canisters per year. Now, the way that this is oftentimes written for an albuterol inhaler is to dispense one and refill perhaps times 1, sometimes refill 0. And because the generic, or there really is no generic, but the typical albuterol canister, regardless of brand, will have about 200 actuations or 200 puffs. So if you recall last week I was talking about asthma control. If your asthma is controlled, you shouldn't need to use this more than once or twice a week, if at all. So if you're using it that infrequently, an albuterol canister with 200 puffs should, if you do the math, last 6 to 12 months. So if someone is refilling it sooner than that, that is certainly an indication their asthma is not well controlled. Now, we don't necessarily count the actuations that you would use, for example, before exercise. Pre-exercise is not counted. But otherwise, if they're using albuterol for any other reason, which is typically to relieve symptoms, and they're using it twice or more a week, that is a sign of not well-controlled asthma. So we're looking for how often they're refilling the albuterol canister, and that's sort of a proxy for how well their asthma is controlled. So we don't usually recommend scheduled use of these medications, which is different from what you would see in someone with COPD. These should be used on a PRN basis, not on a regular basis. In fact, using them regularly may lower the effectiveness and may actually cause the opposite effect and increase airway hyperresponsiveness. Now, there are also anticholinergics. These are ipratropium bromide, which is Atrovent, and ipratropium bromide and albuterol, which is Combivent. These are typically not used on the outpatient setting, and contrast that with COPD, which they are, but they are well studied now as an adjunct to beta agonist in the emergency department. So you'll often see when someone comes in with an acute asthma exacerbation, they may actually alternate treatments to the nebulizer of albuterol alternating with Atrovent, and that can be quite effective. They're just two different methods of bronchodilating the airways. Let's move then to the long-term control medications, and these really are the mainstay for daily control for asthma. The first category are inhaled corticosteroids, and you may recognize, I have both the name and the brand name and generic name there, but you may recognize the names such as Flovent, Qvar, Pulmicort, Asthmanex, Alvesco, Aerospan, and Arnuity. They all work very similarly. They're just different brands, and you can't really compare them molecule by molecule or milligram by milligram. Microgram by microgram, but they all do basically the same role. Then there are combination products, and that includes an inhaled corticosteroid plus a long-acting beta agonist, so an ICS or LABA. And there are 4 combination meds on the market right now. There's Advair, Symbicort, Dulera, and Breo. And they are to be utilized in individuals who are not controlled on the inhaled corticosteroids alone. Then there are also leukotriene receptor antagonists. I'll talk about what those do in just a minute. There are 3 of those on the market, Singulair, Accolade, and Zyflo. There are also methylxanthines, which is a theophylline-based medicine, multiple brands of that. And then there's also an anti-IgE blocker called omalizumab or Xolair, and we'll talk about that as well. So long-term control medications, and this is the opposite of the quick relief medicines. These need to be taken daily and chronically to maintain control of persistent asthma and prevent exacerbations. If they're not taken daily, they are probably not going to be very effective. They can soothe the airway swelling. They're highly effective for preventing asthma flares because they do keep inflammation in check, but they have to be taken daily. So the problem with these medications is they're often underused. It's difficult for patients to understand that they need to take medications on a daily basis. I think I heard someone speaking. If you could put your phone on mute, please. These medications need to be taken daily and regularly. If they're not used regularly, they're not going to be effective. And people may feel that they don't need a medicine when their asthma is well controlled. So when they stop these medications, what happens is they often lose asthma control. And then you compare that to the albuterol, which is overused. These are often underused. And the reason for that is you don't necessarily feel the effects of this within minutes like you do for albuterol. You don't feel that jolt. You don't feel the shakiness. You don't feel that it's working. Sometimes it takes actually up to 2 weeks to get the full benefit of this. So you're not going to see immediate improvement. But once you're on this and you give it a fair trial of a couple weeks and the asthma is under control, what you will see, hopefully, is long-term control on this maintenance therapy. So the actions are that they potentiate the beta receptor responsiveness, and they reduce mucus production and hypersecretion. They inhibit the inflammatory response at all levels. So remember we talked about last week what those basic signs or symptoms of asthma look like, and that is, again, the muscle bands are tightening, the inflammation is occurring inside the airways, there's increased mucus production. The inhaled corticosteroids help counteract all of those effects. You'll see the best effects if these are started early after diagnosis, and you will typically see optimal symptomatic and spirometric improvement within 2 weeks. The maximum effects sometimes even take up to 4 or 8 weeks. So the inhaled corticosteroids, without question, are the most effective long-term control medication for persistent asthma for all ages. So this is for 0 to 105. It doesn't matter. This is the most effective type of medicine on the market in the United States and worldwide to manage asthma on a daily basis. And it really should be the default. So if someone has persistent asthma and they're not on an inhaled corticosteroid, the question should be, why not? There is a small risk for adverse events at usual doses, and we can reduce those risks by using a spacer device and rinsing mouth after using this. Use the lowest effective dose, perhaps add a long-acting beta agonist if appropriate, if they're not well controlled on the inhaled corticosteroids alone. And also we want to monitor growth in children, and I'll talk about those effects in just a minute. We know that using an inhaled corticosteroid actually can reduce the risk of dying from asthma. This was a study done in the New England Journal of Medicine. It's rather old now, I think 16 years ago, but this has been upheld for many, many years. What we see here is that the greater the number of canisters used per year, the lower the risk of dying from asthma. That's a good thing. So, and you can even see that someone using even 6 canisters a year has actually reduced the risk of death by 50%. So these medicines are highly, highly effective. These medicines can also help reduce the risk of asthma-related hospitalizations. So you can see that the pink line here is the number of beta agonists used, and you can see the more beta agonist prescriptions dispensed per year, the higher the risk of hospitalizations. Conversely, the greater the number of inhaled corticosteroids dispensed per year, the lower the risk of hospitalizations. So inhaled corticosteroids, there are certainly concerns about using steroids, and we talked about that a little bit last week. There are certainly patients who have a steroid phobia. There are actually, quite honestly, providers who have a steroid phobia because steroids have gotten a bad rap in the past couple of years because the different type of steroids, like anabolic steroids, have been abused by athletes. This is not that type of steroid. These are steroids that help suppress inflammation, and these are inhaled versus oral. So inhaled steroids, we talked about last time, are measured in micrograms versus oral, which are measured in milligrams. So what you're inhaling is 1,000th of a dose of what you're taking in a pill. So very tiny doses. So we don't expect to see systemic effects from these medicines, typically, if they're used in usual doses. So does this suppress the adrenal glands? We wouldn't expect to see that in usual doses. Will someone develop cataracts from these types of medications? Again, we would not expect to see that in usual doses. And contrast that with oral steroids, which indeed that is a possibility. What about growth? We're asked this question quite often, and we're just beginning to understand the risk with growth and asthma in children, especially those on inhaled corticosteroids. Well, there was a study done initially in 2000 called the Childhood Asthma Management Program, and they looked at children who are on inhaled corticosteroids, compared them to controls. What they found at that time, 16 years ago, was that there was a small transient reduction in growth velocity. So, in other words, they seemed to grow and reach their predestined adult height. It just took them a little longer to get there. Well, they followed that same cohort for another 12 years. And what they found was that it's possible that that growth reduction actually persisted as lowered adult height by about 1 centimeter. But that said, remember we talked about last week that poorly controlled asthma can definitely suppress or stunt growth. Oral steroids can definitely suppress or stunt growth. So you have to weigh the risks and benefits. So if the fear is growth suppression, then I would be much more concerned about someone who has poorly controlled asthma and ends up in the emergency department, the hospital, on oral steroids over and over again. That is a much greater risk of growth suppression than the inhaled corticosteroids. So that's why we definitely monitor growth. We put children especially on the lowest dose possible to achieve control and maintain control. And then we want to step down therapy if it's warranted and if we can without losing asthma control. Another question, is there a concern about osteoporosis or bone fractures? Again, if someone is on high doses of inhaled corticosteroids, we might pay some attention to that, but typically not at the usual doses and not in the usual risk patients. There is definitely a risk of candidiasis or thrush and a risk of dysphonia or hoarseness, and those risks can be mitigated by using a spacing device and rinsing their mouth after they take their dose. The next category is leukotriene receptor antagonist, LTRA. There are two mechanisms for these medicines. So leukotrienes are chemicals that are can spill into the airways and trigger inflammation. So these medications either block the release of leukotrienes or they block the receptor sites in the airway wall. So you have two of them. The inhibitor is xyluten. That inhibits the release of these chemicals, or Zyflow. And then the other one are receptor antagonists. So they block them at the receptor sites, and that would be Accolate and Singulair. And these can be effective. They're alternative therapy in mild persistent asthma, but typically you'll see them added on in higher stages. If, for example, someone is not well controlled on an inhaled steroid alone, we might add a leukotriene receptor antagonist, or even an ICS and LABA. This could be a third tier of therapy. They can improve lung function. They can decrease the need for short-acting beta-agonist use. They can prevent exacerbations. They're not typically used as monotherapy. They're not preferred as monotherapy. They're preferred as adjunctive or alternative medicines. Methylxanthines, which is theophylline. We really don't see this used much anymore. However, because it is still in the guidelines, I have included it here. And there are a couple of select patients who are still on different versions of theophylline. They are used for whatever reason when inhaled corticosteroids are not possible to be used, or patients who refuse to use inhalers, but they are often used as additive therapy at later stages if it's not effective with an ICS or a LABA or a leukotriene receptor antagonist alone. Sometimes this is added in as well. The problem with these medicines is there's a very, very narrow therapeutic range. And if you exceed that range, first of all, if you're below that range, they're not effective. If you exceed that range, levels over 20, it can lead to nausea, vomiting, diarrhea, headache, insomnia, tachycardia, which are more nuisance, but levels over 30 are actually toxic. And that's when you can get into seizures and hyperthermia and brain damage. So there is definitely a concern about that narrow therapeutic range and exceeding that. There are also multiple drug interactions between theophylline and many other medicines that people are typically on. So we tend to avoid these and use them only in select cases. But they are also still in the guidelines. The long-acting beta-agonists, these are like albuterol, but they are designed to last up to 12 or sometimes even 24 hours. These are bronchodilators that help keep the airways open. These are not to be used in an emergent situation. These are not your relief or quick relief or rescue medicines. These are daily maintenance medicines to be used in conjunction with an inhaled steroid. So these are not a substitute for an anti-inflammatory therapy. They are never to be used as monotherapy on their own in someone who has asthma. Contrast that with someone who has COPD, who can be on a long-acting beta-agonist alone, never in asthma. So there is literature that supports adding these medications to inhaled steroids. Again, not for acute symptoms or exacerbations. Salmeterol or Ceravent was the first of its class. Now there's newer LABAs, formoterol and vilanterol. These are newer long-acting beta-agonists. These tend to have a more rapid onset and a longer duration in some of them. So, for example, Ceravent, if it would take perhaps an hour to reach its maximum effectiveness, formoterol might do that within minutes. And formoterol is available in combination with an inhaled steroid in Symbicort and Dulera, which is twice-a-day dosing. Vilanterol is in Brio, which is just once-a-day dosing. Now, what you might hear about is a concern about using long-acting beta-agonists or LABAs. And this came out as a result of a study that was conducted 10 years ago. It actually was conducted before that. It was published 10 years ago. It was called the SMART trial, the Salmeterol Multi-Center Asthma Research Trial. And this was comparing usual pharmacotherapy for asthma or usual pharmacotherapy plus salmeterol. It really was a fairly poorly designed study. It wouldn't even pass the FDA today because people were put on salmeterol plus their usual pharmacotherapy, which may have been nothing. So they could have been given salmeterol without an inhaled corticosteroid. So it was published in Chest, and again, this was published 10 years ago. The study was in patients 12 years and older. They wanted to evaluate the effects of salmeterol or placebo when added to usual care of asthma. And they were looking specifically for two endpoints. They were looking for asthma-related deaths and life-threatening episodes. And they aimed to enroll 30,000 patients and later changed that to 60,000. So it's a large trial. What they found, however, was that there was an increase in adverse events in the salmeterol group during the SMART trial. So they did see a slightly increased risk of death on those folks who were on the Ceravent or salmeterol, particularly though in those recruited in phase 1 and particularly among African Americans who are also noted to have markers of more severe asthma and were less likely to be using an inhaled corticosteroid. So the question is, was this increase in adverse events in the salmeterol group truly due to an adverse effect of salmeterol, or was it simply due to inappropriate use? These patients were more severe at baseline, and they were less likely to be using an inhaled corticosteroid. So because of that study, the FDA issued safety requirements for LABAs in asthma. And what they said is that the use of a LABA is contraindicated without the use of another asthma controller, such as an inhaled corticosteroid. So you could never use a LABA alone in a patient with asthma. If you see that in any of your patients with asthma, not COPD, that would be inappropriate and not guideline-driven and not standard of care. So LABAs should only be used long-term in patients whose asthma cannot be otherwise controlled on a different asthma controller alone, such as an inhaled corticosteroid. They also recommend that LABAs should be used for the shortest duration of time required to achieve control, and then discontinued if possible if we achieve asthma control. And then in pediatric and adolescent patients specifically who require the use of a LABA, the inhaled corticosteroid should also be used in a combination product. So for example, there is still, I believe, a Ceravent discus available, and you would not give that, and typically people wouldn't anyway, but give them a Ceravent discus and an inhaled corticosteroid. You don't want to give them separate components. You always want to give them a combination product so they can't take one without the other. And so that would contain both the inhaled steroid and the LABA, and that would ensure compliance with both medications. They almost removed the indication for LABAs in pediatric patients in 2010. And specialists across the country were up in arms and said, if you take away our ability to provide this medication to our pediatric patients with severe asthma, then you're going to see an increase in asthma death. So they did allow it to be indicated for pediatrics, but they did put these warnings on there. And there's actually a black box warning now on these medications. So you'll see a black box warning on all LABA medications on the market, not just Ceravent or salmeterol, but you'll see them on the others as well. And you'll see the warning, don't use this medication alone, always use it with inhaled corticosteroids. Now the question is, what do we know about adding an inhaled corticosteroid to this medicine? Does that mitigate the risk? Does it really reduce these risks that were identified in that SMART trial? What we're finding is that there is newer data emerging. I don't think there's a definitive answer yet, but what we have found in newer data is that when LABAs are added to inhaled corticosteroids, this is helpful, and there have been multiple reviews and meta-analyses that suggest that long-acting beta agonists plus inhaled corticosteroids reduce asthma hospitalizations compared to inhaled corticosteroids alone. They are effective, and emphasizes the weakness of the primary data. So this is still emerging science. We will still be using ICS and LABA. Never use a LABA alone. And then step-down therapy if you can. So these are the rules of two, 3 quick questions that you can ask your patients or your members, even telephonically, to see whether or not their asthma is under control. And if you recall last week, we talked about how to identify levels of control in patients with asthma, well-controlled, not well-controlled, or very poorly controlled. And we're looking at daytime trouble, nocturnal awakenings, and how often they're refueling their albuterol. So are you refilling your quick relief inhaler, are you using your quick relief inhaler more than twice a week? Again, not pre-exercise, but you're using albuterol because you're symptomatic more than 2 times per week. Are you waking up at night due to asthma? And that could be coughing, shortness of breath, wheezing. Could be they're coughing at night and it's not waking them up, but it wakes somebody else up and they hear that cough more than twice a month. Are you refilling your albuterol canister more than twice a year? So twice a week, twice a month, twice a year. If they answer yes to any one of those questions, their asthma probably is not under control, and those rules help define persistent asthma. If they answer yes to any of those questions, that patient should be on a daily control medication if they're not already on one. If they're already on a daily control medication, it's probably time to step up therapy after you determine they are indeed adherent and using that medication on a regular basis. So we look at asthma severity in terms of intermittent and then persistent, mild, moderate, and severe persistent. And we talked about this last week. That helps us to identify how to initiate pharmacotherapy when someone is newly diagnosed or if they are naive to daily maintenance medications. So someone is coming in for the first time and we're diagnosing them with asthma, or they've never been on a daily controller before, we need to have a starting point. Where do we start in this whole regimen of asthma medications? This will tell us if it's intermittent. Recall that they only need an albuterol inhaler on hand. But anybody who has persistent asthma, mild, moderate, or severe, needs to be on a daily control medication, and that should be an inhaled corticosteroid. So we measure the level of pharmacotherapy here, step 1, step 2, 3, 4, 5, to the stepwise approach. So again, intermittent asthma would be a short-acting beta agonist or SABA as needed. But anybody who has persistent asthma, step 2 through 6, needs to be on a daily control medicine, and preferred therapy according to the National Asthma Guidelines and according to the global worldwide guidelines are inhaled corticosteroids. So you can see, and again, as we talked about last week, you don't have to start at step 2 and work your way up. You could start at step 6 if they're very poorly controlled and work your way down, or start anywhere in between there. It's a very fluid approach. You can step up and step down therapy. If someone is well controlled for at least 3 months, we would want to consider stepping down, at least offer that to the patient. Patient education and environmental controls are important to assess at every step, as is adherence to therapy. Are they taking their medications regularly, as well as their technique, their device technique? Are they using them appropriately and correctly? Every time they come back to the office or every time you contact them by phone, you want to find out after that initial visit how well controlled their asthma is. It's not as critical at that point how severe it is. How well controlled is your asthma? Well controlled, not well controlled, or very poorly controlled. That's every follow-up visit. We're assessing very much the same things: daytime symptoms, nighttime awakenings, how much asthma is interfering with their activity, how often they're using their SABA, short-acting beta agonists. And then we also have those validated questionnaires that we discussed last week, the asthma control test. They have to meet all the criteria in this category to be considered well controlled. So they have to have few or no daytime symptoms or nighttime symptoms, no interference with activity, using their SABA very infrequently, and their asthma control test score would have to be 20 and above. Anything beyond that, the worst feature would place them in the next category. So a score of 16 to 19 is not well controlled, 15 and below is very poorly controlled, or any of these symptoms that we've noted here. And again, you measure that level of control to the pharmacotherapy. So someone who's well controlled, we're going to maintain them in their current step or step down if indicated. Not well controlled, we're going to step up at least one step, reevaluate, and very poorly controlled, we're going to go up at least 1 to 2 steps and reevaluate, and probably consider oral corticosteroids at that point if they're very poorly controlled. So current therapy, we're going to use asthma guidelines as our guide. We know, however, that there has been historically poor adherence with inhaled therapy. Either patients forget, or they're fearful of the medicines, or they don't know how to use the devices. We know there's no curative therapy, and we know that the burden of asthma is still tremendous. We know many patients remain poorly controlled. So there's a new emerging science of recognizing different phenotypes of asthma, and we'll talk about that in a minute, as well as we're going to talk about what are some of the newer medications that are available and what's coming down the asthma pipeline. So some new upcoming therapies. We're recognizing now that there are different phenotypes or endotypes of asthma. So a phenotype is an observable characteristic or clinical presentation. So this is where we're getting into infants or children who may have transient versus persistent wheezing, and which of those, based on risk factors, will go on to develop lifelong asthma. And then there's also endotypes. So that's a subtype that's defined by a distinct pathophysiological mechanism. What's triggering their asthma? So as these treatments become more specific, they're targeting specific inflammatory cells, such as a blockade of specific cytokines or kinases that can be effective in the treatment of asthma. And because these new therapies are likely to be very expensive, especially antibodies, it will become increasingly important to recognize those patients that are most likely to respond. So some of the newer medications include new long-acting bronchodilators. These are just like the LABAs that we discussed before. The traditional LABAs have offered 12-hour duration. That's salmeterol or Ceravent, and formoterol or Fortil. Well, now there are some new ultra-LABAs that offer 24-hour action, and that is indacterol, carmoterol, vilanterol, and olodaterol. The risk of LABAs is still there. Every one of those LABAs, as they come on the market, will have that very same black box warning. Do not use this without concomitant use of an inhaled corticosteroid. They need to be used in a single inhaler device for patients. And risk of overall death if they're using them as monotherapy. We'll talk about a couple new devices as well that are on the market. The first one is the ProAir Respiclick. That's an albuterol sulfate dry powder inhaler. It's also called a breath-actuated inhaler. This is a short-acting beta agonist. It's still albuterol. It's just in a different type of device where you open up the cap and you put it directly into your mouth. You don't use a spacer with this, and you breathe in, and it clicks, and it releases the medicine. Side effects are typical of what you would see in other albuterol medicines, regardless of the type of device. Back pain, body aches, upset stomach, heart racing, shakiness, that sort of thing. There is also a new inhaled corticosteroid that is one 24-hour indication of 24-hour duration. It's called Arnuity Ellipta, and that was approved 2 years ago. It's once daily maintenance therapy of asthma in those 12 years and older. So this is just an inhaled corticosteroid. It doesn't have the LABA with it. The normal dose is 1 inhalation daily, and there are 2 different doses available, 100 micrograms and 200 micrograms. And it is a different device. It's called the Ellipta device, which is dry powder. Side effects, similar to what you would see in other inhaled corticosteroids, again, regardless of what device you're using. Upper respiratory infections, nasopharyngitis, headache, oral candidiasis is probably one of the bigger ones. Again, rinse your mouth and spit after you use these medicines. There's also a new combination medicine on the market that includes a LABA and an inhaled corticosteroid. This one, however, is 1 inhalation once daily. It's called Brio Ellipta. So the Ellipta device is the same device that you'll see in our Arnuity, and this also has an indication for COPD, but it has an indication for asthma as well. This has been approved for ages 18 and older. It still has the LABA warning on it. 1 inhalation once daily for individuals with asthma. Again, typical side effects that you would see for an ICS and LABA and other devices and other brands: headache, nasopharyngitis, pneumonia, and fractures. Then there's also Respimat, which is also a brand new inhalation device. This one, something like the Ellipta or the Advair Discus, the Pulmicort, Flexhaler, those are all called DPIs or dry powder inhalers. Traditional medicines like Dulera, some of the others, the Venolin would be a meter dose inhaler or MDI. This is called an SMI, soft mist inhaler. And this certain device comes with a couple different medications available. One is Combivent, which is a rescue medicine. It's albuterol and ipratropium or Atrovent. Spiriva is tiotropium, and then Stiolto is tiotropium and olodaterol. So tiotropium is a LAMA, a long-acting muscarinic antagonist. That's an anticholinergic, and Stiolto is used in COPD because it has 2 bronchodilators in one, but there's no inhaled corticosteroid. So that would not be used in asthma. So that brings us to Spiriva, or tiotropium, which now newly has an indication for asthma. The dose is 1.25 micrograms per actuation, so 2 actuations once daily. It is indicated as add-on maintenance bronchodilator treatment. in individuals over 12 and over. It's not to be used for relief of acute bronchospasm, and it can be used in patients who are still symptomatic under traditional ICS and LAVA. So this would be adding on a second bronchodilator that they could take on a daily basis. So they would be on actually triple therapy, an ICS, a LAVA, long-acting beta agonist, and a LAMA, long-acting muscarinic antagonist. So 2 different bronchodilators plus an ICS. Adverse reactions, pharyngitis, cough, headache, palpitations, dizziness, dysphonia. Then we get into some of the biologics. Xolair, or omalizumab, is anti-IgE therapy. This is a biologic antibody therapy. It binds the IgE, which is the allergy antibody, in the circulation and prevents it from activating the mast cells and basophils. So anti-IgE therapy, if someone has moderate to severe asthma, can reduce the exacerbation rate and reduce the need for oral steroids. So it is recommended as add-on therapy in individuals 12 years and older who are inadequately controlled on inhaled corticosteroids and long-acting bronchodilators. They need to have an elevated IgE serum level, has to be between 30 and 700, and they also have to have a positive allergy test. So they have to have positive skin prick tests or positive blood tests to traditional aeroallergens, such as tree grass weeds, mold, dust mites, cat dog, that sort of thing. It is indicated for adults and adolescents, 12 years of age and above, who have moderate to severe persistent asthma, positive skin test or blood test to perennial aeroallergens, and their asthma is otherwise not well controlled on inhaled corticosteroids. They have to have that elevated IgE level. Again, it has been shown to decrease the incidence of asthma exacerbations in these patients. So it really is for select patients, not for everyone. The safety and efficacy has not been established in other allergic conditions. However, it did just receive an indication for chronic urticaria, chronic hives, and that's brand new. I will just mention if someone is on Xolair therapy, it is also recommended that they be offered an EpiPen to be used to have with them at all times. And the reason for that is there have been some post-market studies that have demonstrated rare cases of anaphylaxis due to Xolair, and that can be after the first dose or after multiple doses. So it really, there's no pattern that they've been able to see. So that's why they do recommend that that be offered to patients with that warning. It is very rare. Nucala is mepolizumab, which is another biologic to be used in asthma. It's indicated for the maintenance treatment of asthma in people over 12 whose asthma is also not otherwise controlled on current asthma medications. Now this is, we talk about phenotypes, endotype C4. This is for patients with the eosinophilic phenotype. So eosinophils are responsible for airway inflammation and asthma. So if these individuals have a high eosinophilic blood level, so over 150 cells per microliter, they may qualify for this if they're not otherwise controlled on standard maintenance therapy. This helps prevent exacerbations. The dose is 100 milligrams subcutaneously every 4 weeks. I should have mentioned that Xolair is dosed every 2 to 4 weeks depending on IgE level and weight, and that's also subcutaneous injection. Nucala is an anti-interleukin-5, IL-5, so it's targeted therapy for individuals with severe asthma with this specific eosinophilic phenotype. So they have to have severe asthma, and they are not well controlled on current therapy, high-dose ICS, and additional controllers. They have to have an exacerbation history of 2 or more in the last 12 months. They have to have a blood eosinophil level of over 150. They have to obtain a CBC with differential to determine whether or not they meet those criteria. And this is a once-a-month, fixed-dose subcutaneous injection. Adverse reactions, again, potential here with anaphylaxis, so they would also be offered an EpiPen they would carry with them. Headache, dizziness, back pain, and also local reaction at the injection site. Syncare, or reslizumab, it's not easy to say, is also an anti-interleukin-5 monoclonal antibody. This, however, instead of being a sub-Q injection, is an IV infusion. So this has to be done in an infusion center. Indicated for maintenance treatment of patients with severe asthma 18 years and older. Similar to Nucala, it binds to the IL-5 and prevents it from binding to the IL-5 receptor and reduces that eosinophilic inflammation for that very specific phenotype. The dose is 3 milligrams per kilogram every 4 weeks, Adverse reactions, there's again the potential for anaphylaxis. They would also be offered an EpiPen. Cancer, muscle pain. Another treatment that's not really medication therapy per se, but is indeed another treatment for asthma, is called bronchial thermoplasty. This is indicated for the treatment of severe persistent asthma in patients 18 years and older whose asthma is not well controlled on inhaled corticosteroids and LABAs alone. It is invasive. It's performed with a bronchoscope, so it involves the delivery of controlled therapeutic radiofrequency energy to the airway wall. A little device is put into the airways under bronchoscopy, and then those airway walls, the airway is heated. And someone likened it to microwaving, but the airway is heated, and it reduces the amount of smooth muscle in the airway. And the reason for that is because it's those smooth muscles that will go into bronchospasm and close the airways and cause difficulty breathing. So the result is it reduces the amount of that smooth airway muscle. It does require 3 separate bronchoscopic procedures. Again, it is invasive, and it's 3-time procedure because you cannot do the entire lungs in one session because that would cause too much inflammation. It would be life-threatening. But they do one lobe, I believe, at a time. It reduces the asthma exacerbations, ER visits, and hospitalizations, or I should say 1/3 of the lung at a time. There are also newer allergy treatments that I will just mention here because we know that allergies can certainly trigger asthma. Whatever is happening in the upper airways can translate into asthma flares in the lower airways. It's all one airway. So when we get allergies under control, we know that helps to get asthma under control. So these you may not be aware of, but there are some new allergy treatments as well. One of them is the new class is actually called sublingual immunotherapy. So one of them is Timothy grass extract. It's called Grass Tech, and this is used for grass pollen specific allergy. So if someone has, say, tree grass weeds, cat, dog, dust mites, and they have all these allergies that are triggering them, they may not be appropriate for this. But if someone has grass pollen specific allergy, or they know that grass pollen season, which is mid-summer, is their worst season and triggers them on a regular basis, they might be a candidate for this. This is for grass pollen only. What happens is they would start this, it's a sublingual tablet, they put it under their tongue, they get the first dose in an allergy office, they are observed for 30 minutes. If there are no reactions, they are given a script and they take that home, and they take one tablet under their tongue for 3 months leading up to grass pollen season, then they take it throughout grass pollen season. So again, grass pollen season starts, maybe June. We probably would start this in February, March, April, May, June, July is grass pollen. So they would take it throughout, perhaps through mid-July, 4th of July, or the end of July, and then they're done. They need to leave it under the tongue for about a minute, and they start 12 weeks before grass season, indicated ages 5 through 65. Cannot use it in severe or uncontrolled asthma. Side effects are mostly oral, throat itching, irritation, mouth edema, potential headache. They need to stop taking it if they have any severe effects. There's, again, there's also always a slight possibility of a systemic or anaphylactic reaction. It is a lower risk of a systemic reaction with the sublingual immunotherapy than with the immunotherapy injections. So they are also offered an EpiPen for home use. Then there is a different brand of grass pollen extract. It's called Oral Air. Age range here is a little bit different. This is 10 to 65, but again, this is 5 grass species are included in this one, whereas Grass Tech is 1, but there tends to be quite a bit of cross-reactivity between the grass species. 1 sublingual tablet daily, and again, you take it leading up to the grass pollen season and then throughout the grass pollen season. Don't use it in uncontrolled asthma, the same types of side effects, and also offer an EpiPen for home use because of the slight risk, I should say rare risk, but still a possibility of a systemic or anaphylactic reaction. There is also a short ragweed pollen extract available for sublingual. It's called Ragwitech, and this is indicated as immunotherapy for the treatment of short ragweed pollen-induced allergic rhinitis that's confirmed by positive allergy testing to ragweed. Again, dose a 1 tablet sublingual daily. Start 12 weeks prior to the season. So we would typically start this April or May. We would take that May, June, July. That's 3 months. Ragweed starts in August, and they would take it August, September, until the first frost in October. Ages 18 to 65 don't use in severe or uncontrolled asthma. Side effects are very similar to the other sublingual immunotherapy tablets, and the same potential of systemic or anaphylactic reaction. Again, they would be offered in EpiPen for home use. Just a couple more words about the asthma and allergy pipeline, and then I'd like to open it up for questions. So we had talked about SLIT, which is sublingual immunotherapy, and we had just reviewed grass pollen, and we reviewed ragweed pollen. Well, there are some new additional sublingual immunotherapy products that are coming down the pipeline. One is potentially targeting dust mite allergy. The other one is potentially targeting cat allergy. Now, keeping in mind that these can be effective, but if someone has multiple allergies, they may still do better on the subcutaneous or the allergy injections. There's also going to be a generic version of Advair, which is going off patent, coming up probably in the next year. But knowing, however, there may be up to 8 different companies working on this, so there could be 8 different generic versions, and they could all be using 8 different devices. And so what we could see is a new dry powder inhaler. We could be seeing a new soft mist inhaler. We could be seeing a new meter dose inhaler or something entirely different. So we as care managers really need to stay on top of those devices and techniques, because someone could be getting a prescription filled for a generic version of an inhaler with a brand new device that no one has ever seen before, and they need to know how to use these. There's also an intelligent control inhaler coming out. There's multiple companies working on these smart inhalers, and this actually provides data on inspiratory flow. It has integrated patient instructions. It actually has profiles to help them monitor their disease progression. There's another one by Novartis. It's a BreezeHaler, and that's a digital inhaler device that's integrated with your smartphone. We do expect to see a generic albuterol coming out soon, probably by the end of 2016 or in 2017. And then we had talked about biologics. There are other biologics in the pipeline, and these are targeting different inflammatory mediators. Instead of the interleukin-5, we're looking at additional IgE antibodies, IL-13, and IL-4, and there are many coming out. They are going to be, again, very expensive, so they really need to be targeted to the right patient. But they can show promise, especially if they have not had asthma control until now. And then you may actually see an inhaler coming out that has 3 different medicines in it. That's called triple therapy. So it may have an inhaled corticosteroid, it might have a long-acting beta agonist, and it might have a long-acting muscarinic antagonist. You'd have a steroid, you'd have a bronchodilator that is a long-acting bronchodilator, and you'd also have a long-acting anticholinergic bronchodilator, all in one device. So a lot coming out, and we need to stay on our toes, really on our toes, and help patients understand this barrage of new medicines that are coming out and new devices, new treatments for asthma. It's a very exciting time for asthma and for patients who have asthma, but they need to know how to use these devices correctly, and it has to be the right device for the right patient at the right time. So I'm going to just conclude with success. How do we know when the patient is achieving success with their asthma? How do we measure it? How do we get there? Again, we begin therapy based on severity. How severe is your asthma? We marry that pharmacotherapy step to their severity. But on every follow-up visit, we're going to be monitoring control based on their risk and how responsive they are to therapy. We are going to use routine, standardized, multifaceted measures for control. That includes monitoring symptoms, monitoring daytime trouble, nighttime trouble, monitoring their lung function, monitoring their asthma control test scores, monitoring if they're having symptoms with exertion or with exercise, if it's affecting their daily activities. The goal of therapy is to achieve control and maintain control. So it really will most likely take individualized therapy based on the likelihood of their response and their patient's needs and their desires and their goals. So I'm going to leave it there. I do have links to the guidelines, the full guidelines that are 440 pages. These are the Expert Panel Report 3 guidelines, but there's also a summary report that's a little shorter than that, and I have that summary on there as well. So if you want to learn more about this, now you're not going to see the newer medicines, listed in the guidelines because the guidelines were published in 2007. As I said last week, there are also the GINA guidelines, the Global Initiative for Asthma, and those are updated almost yearly. The latest version of those came out in April of 2016, but you might see some medications there that are available, because they're global, you might see medications that are available in Europe or Canada and not available in the United States yet. So keep that in mind. I'm happy to answer any questions you may have, and I thank you for your attention today.
Unmute. Had to mute all and then unmute. Phone is on.
And you can also type questions into the chat box as well.
To mute Amy, and then unmute.
All guests have been muted. All guests have been unmuted.
Oh, I see a question there. I tend to see a lot of non-compliance with inhalers due to their high cost. Any resources or suggestions you have for this? That is a great question, and yes, that it can be a barrier for patients. The inhalers can be quite expensive, and as I said, with the newer medications coming out, they are going to be more expensive yet. A couple suggestions there. If they have insurance, there are copay cards that many of these manufacturers will offer to patients, and they can use those copay cards to bring down their copays. If they have absolutely no insurance, they may qualify for prescription assistance programs and get the medications for free. And if they do have insurance, I would suggest that they contact their customer service or their benefits coordinator to find out, because most health plans will cover several or at least one inhaled corticosteroid. They'll cover at least one medication from each category. So they may just have been prescribed the wrong one that might be a higher tier. So I would have their provider or the patients themselves check with their insurance provider and see what are the preferred medicines in those categories, and they probably will get them at a lower cost. Okay, what is your take on the EpiPen situation? Yes, don't get me started on that. I was very, very troubled, I'm sure as all of us were, about the skyrocketing cost of this life-saving medication. I think it's, quite honestly, and it's just my opinion, is unconscionable to offer something at that cost and to see that price just skyrocket the way it did. There are alternatives. If a provider writes for a generic EpiPen, they may be dispensed a lower cost version of that. There is the Adrenaclick, and that may be at a lower cost. There are also copay cards that this company is offering to bring down the cost, but bringing down the cost from $600 is still quite expensive. So unfortunately, I think there are people out there who are simply not getting their EpiPens filled, and that is a big problem. I found issues with the high deductible plans, so they wouldn't qualify for prescription assistance. Any creative ideas? That is also that's a barrier that is difficult if they have the high deductible plans. But again, sometimes they can work with their providers and get a lower cost version if they go to if they work with their benefits coordinator or customer service to find out. Because oftentimes, providers don't realize that there might be a couple meds in the same category. They don't realize that one is just simply going to be less expensive for that person, that member, than another one. And they may be prescribing something that they have a sample for, but not necessarily the best one for that member or that patient. So I think really just paying attention to what those benefits provide, I think they'll be better off, because there may definitely be less expensive versions of that. There are multiple versions of all of those medicines in every category, so they just need to find the right one for them. And I think as we see more generic versions coming out, I think that will drive down the cost. As I said, there should be a generic albuterol coming out, hopefully later this year, early 2017. When the generic Advair hits the market, I think that will drive down the cost of the ICS and LABAs.
And as a reminder, you can also ask the question over the phone line. So if you would rather, you can also ask the question over the phone line.
Mm-hmm. A comment from Joyce. Thank you, Joyce.
Well, if you're thinking of questions, I'll just remind folks to make sure you register and return your evaluations. That's how we can administer the continued education. Karen provided a nice reminder that the first webinar was also recorded, so you can access that via the website at www.mi-CCSI.org. We also recorded this webinar, so if you have colleagues that were not able to attend today, they can come to our website. It takes us about a week before we get everything pulled up and together available, but they should be able to come to the website and also access the information, so it's available to those that weren't able to attend live today. Any other questions before we end the webinar today? Any last thoughts? You can either ask them through the chat line or on the phone. Right. Well, with that, Karen, again, thank you for a wonderful presentation, great information. And again, too, if folks have questions, please don't hesitate to send them. You can send them via our website, or you can have your access to Karen's information as well. So we want to help you be successful and are eager to help you where you have questions or running into complex cases. So make sure you give a shout out for that.
Yes. And Sue, if you could just remind everyone the webinar next week, same time?
Yes, next week, same time. We have the information on our website. You can sign up and register there. And if you aren't able to attend it live, again, we'll be recording that and we'll continue on. We have a series of 6, so I'm hoping you will be able to join all of them, but certainly we understand our work environments don't always allow us to do that, so we make the recording available as well. So thank you, everyone. And, again, thank you, Karen, and special thanks to Priority Health as well. So
you bet. And thank you, Sue, and thank you, everyone, for listening in today. Thank you.
All right.
Thank you. Everyone have a great weekend.
Yeah.
Thank you.
Sue?
Bye-bye.
Yes. Bye-bye.
Can you say again how to get the CE? I'm already registered for all of these.
You did register. Okay. If you registered, the evaluation should have been sent to you. You should have gotten an email. In the email would have been the attachment. If you did not receive that, please let me know. Just send us an email, and it's sue.voss@MICCSI, MICCSI.org, and we'll make sure we get that to you.
Okay, thank you.
All right. Okay, thank you, everyone. Have a great afternoon.